My name is Leonardo Kruschewsky from Salvador, Bahia, Brazil, and it's a real honor to be here and have the opportunity to present our very first fresh parathyroid allotransplantation involving healthy living donor and immunocompetent hypoparathyroid recipient. I have no financial closures, and I'm a head and neck surgeon since 2001. Hypoparathyroidism is one of the worst troubles that we may have after a total thyroidectomy, especially if it's combined with central neck dissection or inhale operation cases. The first successful parathyroid allotransplantation were described in the beginning of the 70s using previously diseased donors with hyperplastic glands and recipients already on immunosuppression for kidney transplants. Nowadays we have two kinds of donor types. The diseased donors with generally hyperparathyroidism and the healthy donor glands, usually relatives and cadaveric specimens. Immunocompatibility is critical to avoid graft rejection. The good news is that parathyroid cells weakly express HLA class 1 and 2 compared to other tissues. HLA, ABO, cross-matching, all these studies are very important to find a compatible donor-recipient pair. And the immunosuppression techniques may be as short as 1 week, 1 month, or as long as 1 to 3 years suppression. Corticosteroids, tacrolimus are drugs used, prescribed, and we try to find effective immunosuppression and its complications like neoplasia and opportunistic disease and infections. Our patient is a 43 years old woman, mother of 3 children, that was submitted to a total thyroidectomy in November 2021. The pathological findings showed a PT1A-M PN0 right papillary carcinoma, and no parathyroid glands were removed or presented on the specimen. A couple of months later, she began to complain with paresthesia, tetany, and she needed to be admitted on the emergency room with a high severe hypocalcemia and treated by IV calcium. And in June 2022, she was diagnosed with permanent hypoparathyroidism and renal tubulopathy. She needed to use since that moment, 15 capsules a day of calcitriol, 6 capsules a day of calcium, and despite that, she continues complaining of weakness, fatigue, anxiety, needing 2 to 4 hospitalizations per year to IV treatment, and she began to develop nephrocalcinosis and mediastinal calcification, and she expressed at that time a marked disease in her quality of life. She began teriparatide 134 in September 2024, and because of its high costs and the high incidence of osteosarcoma induction, the medical team initiated to discuss Parathyroid transplant for her. At that time, the interdisciplinary team had some challenges: how to choose the donor patient, gland selection and its techniques to implant, the choice and the period of immunosuppression, and how to follow up even the donor and the recipient patients. At that moment, we submitted for the ethical committee of the hospital this probability, and we had her brother and mother as volunteers. The immunological studies between the patient and her mother showed a 50% HLA identity, a negative cross-match flow cytometry, parasitologic treatment, prophylactic treatment for parasitosis, serological tests and adequate vaccination were performed in both patients. And because the donor patient was a healthy donor, we dedicated a lot of time and effort to explain, warn, and clarify all the surgical risks that this patient could be, even the post-surgical risks like hypoparathyroidism. We selected the two right parathyroid glands, localized by ultrasound, and the immunosuppression was based on kidney transplantation protocol, markedly with very low maintaining dose. Talking about the surgical technique, you may see the right thyroid lobe presenting here with the first parathyroid exposed, and the right vocal fold identified and preserved. Immediately after taking it off, we began to cut in various pieces, and we chose the non-dominant left forearm of the recipient, where we did 4 little pockets on the brachioradial muscle fascia, and we put all the grafts on these 4 little pockets. Here you can see very discrete scars on the donor neck and on the forearm of the recipient, and some results now. We may see that PTH blood levels were as low as 8 before the transplant. It increased a little with the recombinant PTH for 11, and after 24 hours we had this happiness result growing to 20, and 3 days after it was 41. It continues maintaining a very good level of 44, 50, 76, 69, 59 after 3 months. And here we can see the contrast enhanced ultrasound showing on the left side very well vascularized graft. Recipient and donor maintain normal blood calcium levels since transplantation. Calcium replacement was quit after 6 days on the recipient patient. The donor patient never needed for calcium replacement. Donor evolution, she had no complaints, and these exams are from last week. You can see on the graph that her calcium blood level continues always normal with no supplementation, despite this little low PTH. For highlights, we try to bring the importance of healthy parathyroids. Maybe it could offer best viability on the transplant, despite the risk of hypoparathyroidism, more or less 0.1%. The immunocompatibility is crucial to graft success, and we decided to reduce the dose of suppression 3 to 4 times and maintain it at least 1 year long-term period. I tried to present in 10 minutes. That was the organization asked, and I'd like to say that it was a real satisfaction, delighted feeling to see this patient, that a very suffered patient, begin to feel very well since the first day after the transplant. I want to thank for our team. We do nothing alone, that's important, And again, thanks for the opportunity to be here.